Hello everyone, Chris here. This session we're going to look at chest percussion, postural drainage, and adjunctive breathing techniques. All right, let's get started. Chest percussion and postural drainage. Percussion is a technique of clapping on the patient's chest wall with cupped hands. Of course, this is the manual procedure. Hand position is approximately 3 inches from the patient's chest. Strike the chest wall in a waving movement, alternating with each hand. A small air pocket is trapped, inducing a vibration through the lungs. Avoid bony structures like the spine, the sternum. Avoid the abdomen and breast tissue in female patients. A mechanical percussor can be used to perform percussion or chest physiotherapy. As you can see, there's an example of the G5 that is a mechanical percussor. A mechanical percussor allows for high quality percussion to be given without tiring the therapist. It takes a lot of energy to provide manual percussion or CPT, and if a RT has many patients on their assignments, it could be very difficult to provide high quality for all patients. That's where a mechanical percussor can be very effective. Postural drainage is a technique using body positioning and gravity to facilitate the removal of pulmonary secretions. The rationale for postural drainage is a principle that water runs downhill. Take a look at the graphic on slide 6. It illustrates the 12 body positions and bed positions required to drain particular segments of the lungs. Remember, the tracheobronchial tree is a very complex architecture and requires these different positions to drain the particular lung segments. If you can take a look at the very top 2 graphics, the upper lobes, you'll see on the left the anterior apical segments are drained with the patient in what appears to be a semi-Fowler position. However, the posterior apical segments, the patient is sitting forward in order to drain the right upper lobe and the left upper lobe. So it's important for the respiratory therapist to memorize these positions because there's a good chance you might get some questions on your MBRC exam relating to the postural drainage and positioning, as well as to be able to execute physician's orders on such drainage. So it's very important that you spend some time looking. All right then, let's go ahead and move on to adjunctive breathing techniques. Diaphragmatic breathing. Diaphragmatic breathing may be accomplished on both inspiration and expiration. The RT will encourage the patient to distend the abdomen with inspiratory effort. Use of the abdominal muscles in this way helps to lower the diaphragm, expanding the lungs further. On expiration, the patient is encouraged to flatten the abdomen, thus pushing the diaphragm up and improving the strength of exhalation. With time, this contractile force of the abdominal muscles will increase and, of course, improve the patient's overall ability to take those big breaths. That's the big goal here, is to really provide that training over time. Pursed lip breathing. For pursed lip breathing, the patient is instructed to take a deep breath and exhale through pursed lips. The narrowing of the airways generates a resistance to exhalation, causing pressure to be maintained throughout the bronchial tree. This sustained pressure prevents air trapping and keeps the alveoli inflated for a longer period on exhalation. This is a natural phenomenon that may be observed when a patient is short of breath. Pursed lip breathing is a common addition to any pulmonary rehabilitation program or care plan. Next is the directed cough. The patient is instructed to take 3 deep breaths, as deep as possible. This maneuver will help to reverse atelectasis and increase the volume available for coughing. At the end of the 3rd breath, the patient is encouraged to cough twice very firmly. So again, directed cough is really an excellent way to have the patient breathe maximally to provide the volume and flow that is required to produce an effective cough. Splinting. Splinting is a technique where the surgical incision or injured area is supported with the hands, a pillow, or a blanket. By applying pressure across the incision and minimizing its movement, pain during coughing is reduced. When pain can be reduced, cooperation is generally better. The patient's more willing to work with you to take a big breath and to cough effectively, which of course is very, very important when a patient is post-op. Unilateral chest expansion. This technique can be helpful in reversing middle or lower lobe atelectasis. By placing a hand along the mid-axillary line, expanding one side of the chest preferentially. Therefore, when the patient performs deep breathing, the side where the hand is placed expands. Again, very helpful in re-expansion of atelectatic areas. A very simple technique as well. Acute chest compression. Helpful for those patients with a poor cough effort or weak muscles. The patient is instructed to take a deep breath as possible. Then hands are placed on the patient's lateral costal margins. When the patient exhales, apply firm but gentle pressure. This helps to generate the flow and pressure necessary to move secretions into the larger airways where the patient can cough and expel the secretions. In conclusion, these techniques are very important techniques for the respiratory therapist. Important for RTs to memorize all of the postural drainage positionings, as well as the adjunctive breathing techniques and the way to instruct your patients to utilize these techniques fully. Really appreciate your time. Thanks for watching. And until next time, everybody, please be well.